In this particular section, we are going to discuss on the subtypes of pneumonia, more importantly, the aspiration pneumonia and lung abscess and hospital-acquired pneumonia and ventilator-associated pneumonia. So these are the things we are going to discuss in this particular video. So what do you mean by aspiration? First, aspiration literally means just inhalation of foreign material into your respiratory tract. That's what it means. So just inhaling some foreign material into your respiratory tract. That's it. What are the risk factors for aspiration? The number one risk factor for aspiration is going to be the low GCS. Whenever the GCS is low, your airway protective reflexes will be weak, and that is the reason why you are more prone for aspiration. Among the declining cause of GCS, the most important in our community is heavy alcohol intake. Yeah, knocking out with alcohol is one of the main risk factors for developing aspiration. And next, whenever the patient is having some neurodegenerative disorders, obviously they are highly prone for aspiration because of the slowing of the movements like Parkinson's disease or in Alzheimer's disease where the cognition is poor. A lot of neurodegenerative disorders predisposed to declining GCS, and that could be the main reason for aspiration. In fact, one of the most common cause of death in patients with Alzheimer's disease and Parkinson's disease is aspiration pneumonitis and death. So that's why this becomes a very important cause in those patients for death. So you have to understand this. Next, patients might be under influence of heavy sedation. This especially happens in ICU patients where they will be usually under a strong sedative, or if the patient is having a general anesthesia. So these are the conditions, these are the areas where the patients are very prone for aspiration, low GCS. Apart from the low GCS, they can develop aspiration through GRD also. And this GRD is especially important reason for aspiration in a common public where they tend to aspirate small amounts of gastric content for a long period of time, which might result in long-standing or chronic chemical pneumonitis, which might even predispose to ILD. So chronic GRD patients, there is one study which is telling they are predisposed to development of ILD and fibrosis in the future. So the validity of this study is questioned, but still this is being proposed as one of the main reasons for interstitial lung disease. Or in patients who are having esophageal motility disorders, obviously yes, they are prone for aspiration as well. So these are the risk factors in general for developing aspiration pneumonitis. And at the same time, we are going to discuss on the classification of aspiration pneumonitis and the subtypes of aspiration, where you have different types of aspiration which is going to result in different types of pulmonary sequelae and different types of clinical features and treatment options also. So let us see that. So first let us put a table. So where you have inoculum, then a pulmonary sequela, and what will be the clinical features, and finally what will be the treatment. The first, inoculum, acid or bile. So whenever you aspirate acid or bile, the pulmonary sequela is going to be chemical pneumonitis. And this chemical pneumonitis is what we refer to as a famous terminology called Mendelssohn syndrome. And how much chemical compound, how much acid or bile is required to produce chemical pneumonitis. But we are going to discuss about this acid only because bile aspiration is quite rare, but acid aspiration is very, very common. So what is the nature of the chemical compound, that acid, that is essential to produce chemical pneumonitis? Roughly you need approximately 25 ml of gastric content at a pH of less than 2.5. So this is the usual rule of the chemical compound, for the chemical compound to produce aspiration pneumonitis or chemical pneumonitis. Clear? So the clinical features will be usually acute dyspnea and tachycardia. So this will be the usual clinical feature. With this only we are going to identify. Plus or minus, rarely the patients may go for severe bronchospasm and cyanosis. That is because of the airway reactivity. So suddenly when an acid comes and touches airway, they can go for bronchospasm, and they go for hyperreactivity, and they go for cyanosis and even respiratory failure and death also. They might have fever as well. So these are the not so common entities, but still you have to keep that in mind. So these are the two important things, acute dyspnea and elevated heart rate. Obviously chest X-ray will show infiltrates in the dependent portions. Dependent portions, I will tell you what are the dependent portions later on. So dependent portion in the sense these are the areas that are prone for aspiration. Most of them will be on the right lung only. We know our right lung is the one that is prone for aspiration and entry of any foreign material into the respiratory tract. So on the dependent portions, especially in the right lung, certain areas are more prone in certain positions, which we are going to discuss in some time. So there you will see the infiltration. ABG obviously will show sudden desaturation and hypoxemia. And treatment wise, it's fully supportive treatment. We are going to treat with IV fluids, tracheal suctioning, and a positive pressure ventilation. So these are the general treatment options that you have. Clear? So this is the chemical pneumonitis. And second, we have aspiration of oropharyngeal bacteria. Aspiration of oropharyngeal bacteria. So what will be the pulmonary sequelae? Pulmonary sequelae will be bacterial infection. This will be the pulmonary sequelae, and they will surely ask you, this bacterial infection tends to be polymicrobial. These bacterial infections tend to be polymicrobial. Whenever I tell the word polymicrobial, means there is contamination with anaerobic organisms. The moment I call polymicrobial means there is contamination of anaerobic organisms also. That's a very important word, especially when you aspirate oropharyngeal bacteria. Remember, at any aspiration, usually there will be some oropharyngeal bacteria that will be contaminated along with the aspirating material. So this is a very common entity, but this is the sequelae. We are talking about the subtypes. That's why I'm telling it as a separate event. So what will be the clinical features? If you purely aspirate only the oropharyngeal bacteria, they will be more of an insidious onset, which means very indolent. They can have symptoms for a long time, but without coming to the hospital. And they have fever, cough, and this cough will be productive cough, and you will be expectorating frank pus. That's why we call it a purulent sputum. And chest X-ray, again, you will have infiltrates in the dependent portion. Infiltrates or even abscess in the dependent areas. Clear? So in late stages, you might even see a cavitation. That's what we call a classic lung abscess. In late stages, you might even see a class cavitation, but it's not common in early stage. Early stage, you will get only infiltration, suggestive of infection, but later on, you might see even a frank cavity formation also. Treatment-wise, obviously they are going to be treated with antibiotics. Plus or minus interventional options are also there in late stages when the cavity has formed and it's very big and it's not responding to antibiotics. In the sense there you can do intervention, but ultimately your antibiotics are the mainstay here. So these are the features when you aspirate a oropharyngeal bacteria. Suppose when you are going to aspirate an inert fluid. So inert fluids means when you are aspirating saline, the barium content. So when you're doing a barium swallow testing, so when you aspirate those saline, water, barium, so these are inert compounds, inert liquids. So usually they don't cause chemical pneumonitis, they don't cause inflammation as such, but they can cause mechanical obstruction. Mechanical obstruction, that is because of reflex airway closure, and again because of hyperreactiveness of the airways. So that only they go for constriction. Reflex airway closure. So that's the reason. Again, they are also going to present in a very similar way, in a very acute way, acute dyspnea, plus or minus they can even go for cyanosis and respiratory failure because of this reflex closure of the airways, reflex bronchospasm. And treatment-wise, again, is going to be highly supportive treatment like tracheal suctioning and positive pressure ventilation. So this is going to be the main treatment. Clear? So again, very supportive treatment. But inert fluids usually do not cause any much of chemical pneumonitis, or they won't cause much of infection-like features. So they will be usually acute in presentation. Number 4, when you aspirate a particulate matter, like a coin, like a peanut, it's very common in children actually, compared to that of the adults. When you aspirate a particulate matter, again the main problem will be mechanical obstruction, and the clinical features will depend on the level of the obstruction. What is the level? More proximal it is, more the patient is prone for respiratory failure and severe respiratory distress. Proximal will be usually severe, and they'll go for frank respiratory failure very, very fast. More distal the obstruction is, usually it results in more chronic features. Whereas proximal, I told you, it will be more of acute clinical features. Distal, it will be more of chronic clinical features. Chronically, they can have irritative and productive cough, plus recurrent infections, very common in that area. They can even form a local focal bronchiectasis also, because foreign body is one of the main reasons for this particulate matter, and foreign body are one of the main reasons for a localized bronchiectasis. They can go for a recurrent infection, localized bronch, because of the inability to clear off the secretions. That becomes a nidus for infection for the bacteria. So they can go for recurrent pneumonia and infection like picture. So again, in the foreign body, where it lodges is very, very important. More proximal the airways are, more acute the presentation will be, and more faster the patient will go for respiratory failure. So this is what you have to understand. And treatment-wise, most important is extraction of the particulate matter by rigid bronchoscopy. Especially if it's in the proximal airways, the only option is put a rigid bronchoscopy and try to take the foreign material out, the extraction of the particulate matter. Otherwise, the child who has inhaled the foreign body might die very fast, because this is a condition that produces tremendous increase in the work of the breathing, and they might go for a faster respiratory failure. You have to be very, very sure about that and very careful about that as well. Suppose if you have a superimposed infection, you can use antibiotics. So this is going to be the treatment. These are the 4 types of aspiration that I want to tell you. Number 1 is the chemical pneumonitis, where you inhale the acid or bile. Second one is the aspiration of the oropharyngeal bacteria, which typically produces infection for a long time, chronic infection in the lung. So third one is aspiration of inert fluids. Usually there will be acute in presentation, like how you get a chemical pneumonitis, where mainly the problem is due to mechanical obstruction and reflex closure of the airways, or reflex bronchospasm. And number 4, finally, when you aspirate a particulate matter, the main problem is mechanical obstruction. So depending on the level of the obstruction, you will get the severity of clinical features. Now we are actually looking on the aspiration sites, and these are the classic dependent areas in the lung which are more prone for aspiration. You can see all the sites I have mentioned are in the right lung. You know very well the reason why, because the right bronchus is more straighter, more wider, at the same time it is more shorter also. That's why the right lung is more prone for aspiration. And what you can see here is the fact that in right decubitus posture, 2 areas are prone for aspiration. One is the posterior segment of the right upper lobe, and the right medial lobe, especially the medial segment of the right middle lobe. So these are the sites that are prone for aspiration if the patient is in right decubitus posture. Supposedly, if the patient is in erect posture, that is maybe sitting or standing position, very rare to get aspiration, but if they are getting aspiration in that particular posture, the usual area of aspiration will be posterobasal segment of the right lower lobe. Fine. When the patient is in supine position, what will be the site of aspiration? That will be the superior segment of the right lower lobe. So this is the most common site of aspiration whenever the patient is in the supine position. So overall, this is the most common site for aspiration, because most of the aspirations happen when the patient is in supine position only. So remember in exam, even if you don't remember all these sites, just remember this superior segment of the right lower lobe. You might ask me why I have mentioned this in the middle lobe in this diagram. It's because of anatomy, because the superior segment of the right lower lobe is little bit posterior when you look at the anatomy of the lung. Clear? At the same time, when you see from the anterior aspect of the lung, the lower lobe will be a little bit low. When you see from the posterior aspect of the lower lobe will extend a little bit higher. That is again because of the oblique fissure and the horizontal fissure that is present on the right lung, which divides lung into different lobes in a very different manner. So that is the reason why I put in a dotted line also. So this again because of the anatomy. So don't get confused. So superior segment of the right lower lobe is the most common site for aspiration overall, and also is the most common site for aspiration when the patient is in supine position. Let us move on. So now we are moving on to the next disease, that is called a lung abscess. So first, let us know about the risk factors for lung abscess. It's almost the same as that of aspiration, which means anything that makes the patient more prone for aspiration will also make the patient more prone for lung abscess also, which also means that declining GCS in the form of alcohol, neurodegenerative disorders, sedation, general anesthesia, all these things once again are going to produce risk for lung abscess also. Second reason may be due to something that causes a bronchial obstruction. Whenever something causes a bronchial obstruction, I'll think about a foreign body, especially in the distal airways. It may not produce immediate symptoms. It might be indolent for a very long time and then produce a lung abscess plus or minus bronchiectasis for a long period. So foreign body. Second, I think about a cancer causing bronchial obstruction and producing a lung abscess like presentation. Very important cancer that you have to know is a squamous cell cancer, out of which most of the squamous cell cancers that you get in exams at least tend to cavitate. So one of the strong differential diagnosis for a cavitating lung lesion and a lung abscess like presentation with thick walled cavities is squamous cell cancer. So cancer. Number 3, it can be present in patients who are having bronchial stenosis, which is per se a very rare clinical entity to encounter. So these are some of the reasons for bronchial obstruction. Then you can get lung abscess in immunocompromised state. Immunocompromised state can produce lung abscess due to any organism, but please think about one important organism in a post-transplant individual, especially after a solid organ transplant. This is very, very notorious organism called nocardia. Whenever in an exam you get a patient with pneumonia-like presentation and the patient is having a cavitating lesion or any lung abscess-like presentation which is not responding to standard antibiotics that you're going to give, and especially if the patient is a post-transplant individual, think about nocardia as a very important cause. Don't forget. Finally, infective endocarditis. Infective endocarditis can cause lung abscess, typically if it's a right-sided endocarditis. Very commonly, right-sided endocarditis only will produce a lung abscess. And what will be the distribution of this abscess? Usually, since this infective endocarditis causing abscess is due to septic emboli, it will be more peripheral in distribution because it will distribute in the pulmonary circulation. So there will be more peripheral in distribution, and especially in the periphery when you are seeing multiple consolidations like appearance. We'll discuss about what is consolidation later on in detail in the ILD section. But now, as of now, when the patient is having a consolidation or a cavity formation, clear? So a nodular-like appearance with surrounding infiltrates. So especially if it's in the peripheral distribution and if it's multiple, think about an infected endocarditis causing a septic emboli to the lung, causing lung abscess like presentation. Very, very important. Clear? So this is how you suspect infected endocarditis. So these are the risk factors for developing lung abscess. Now we are moving on to the pathogens that are going to cause lung abscess. What are the pathogens that cause lung abscess? Pathogens that cause lung abscess, we can split into two. Lung abscess may be a polymicrobial infection or it could be a monomicrobial infection. As I told you already, since aspiration is the most common reason for lung abscess, polymicrobial infections are extremely common. I told you again previously some time back, polymicrobial means there must be anaerobic contamination. Very, very common in a lung abscess, anaerobic contamination. Clear? So what are the anaerobes that are very commonly and likely to be encountered in a lung abscess patient? Number 1 is Peptostreptococcus. Remember, this is a streptococcus only, but an anaerobic streptococcus. That's why it's a gram-positive anaerobe, Peptostreptococcus. And this Peptostreptococcus is supposed to be the most common anaerobic organism encountered in a lung abscess patient. Second, it can be due to Fusobacterium species. Other species that can cause lung abscess is Prevotella and Bacteroides. But please do not confuse this Bacteroides with Bacteroides fragilis. Bacteroides fragilis is an exclusive intra-abdominal anaerobic organism. Clear? So don't confuse that. And monomicrobial organisms, rare generally. You don't encounter lung abscess with monomicrobial organisms. If you encounter, if they ask you the most common monomicrobial infection causing lung abscess is Staphylococcus aureus. At the same time, this is the most common aerobic organism causing a lung abscess. We saw the anaerobic organism. Now this is the most common aerobic organism causing lung abscess. It can be seen due to Klebsiella, or it can be seen due to Streptococcus pyogenes or Streptococcus aeruginosus. All these organisms can produce lung abscess. Clear? So these are the pathogens. Now let us move on to the clinical features. Clinical features, the first point I'm going to tell is the fact that lung abscess tends to be indolent for a very long time. Since it's due to infection and it's subtle infection, it's not overt infection that causes severe pneumonia, respiratory distress initially itself. It's a very localized infection in the dependent area, which cooks up for a very long time and comes to you when it becomes more and more severe and when the cavity size is expanding. So that's how it comes. So which is very indolent. So it's going to cook up for a very, very long time. So that's what we're going to see, indolent clinical presentation, which means it's going to be subacute to chronic in the sense they can be presenting on cooking up over weeks or months together. So first one, fever. Fever is a very important clinical feature and tends to be associated with no chills and rigors. Because whenever you study about the abscess anywhere in the body, they tend to produce chills and rigors, but this does not produce chills and rigors. The degree of fever may be low to moderate to high grade, but there will be no chills and rigors usually, very commonly. They produce productive cough as well, chronic productive cough, and this sputum that they are going to produce tends to be foul smelling and tends to have a postural variation, in the sense they increase with supine posture, again with dependent posture, like bronchiectasis. So productive cough, very important. And they can produce other TB-like features like weight loss, night sweats, and even hemoptysis. Which means when you see a fever without chills and rigors, productive cough, weight loss, night sweats, hemoptysis, you think about TB in India unless proved otherwise. And chest X-ray also is going to show a cavity also. Like when you see a cavity, weight loss, fever, hemoptysis, you generally think in terms of a TB. But there are some features that differentiate TB from this, because the history will tell you there is some risk of aspiration, some evidence of aspiration will be there. At the same time, the cavity features also will be a little bit variable in a lung abscess. Let us see. That's why we are going to see the diagnostics in the next section. What are the investigations that you can do? Diagnostics wise, obviously we'll take the sputum first, and you'll be doing a gram stain and a culture. Obviously, you will do a gene expert, that is CB0 for TB also, and you will be doing a AFB testing also. I'm not telling you you won't do that, but as a part of general profile, you will do that. But still, this gram stain culture may yield some organism, but still, whenever they yield some organism, they tend to be of low specificity also. You might ask me, sir, culture is the gold standard, you told 100% specific. But in this setting, you can't diagnose a lung abscess with a culture growing an anaerobic organism, because you really don't know where the organism is coming from the lung, or when the sputum comes out, it is contaminated with the oral bacteria, because the same thing that caused the lung abscess as well. So you may not be very sure that this is a oral contamination with saliva causing the growth of that organism in the culture, or it's really a organism that is grown from the sputum in the lungs. So you have no idea. So that's why I'm telling in this particular regard, it's going to have a low specificity for diagnosis. Then radiological imaging, CT or chest X-ray. What you're going to see in a CT or chest X-ray is a classic thick-walled cavity with air fluid level. Clear? So when you have a cavity which is thick-walled with the air fluid level, I can show you this in air, this is fluid, the wall being very thick. Whenever the wall thickness is more than 5 millimeters, we are going to call it as a thick-walled cavity. So we can see the image so that you will understand better. So this is the image you can see. So you can classically see a thick-walled cavity with the air fluid level. Okay, this is air. You are seeing in the right upper lobe, isn't it? So this is a classical image of a lung abscess. And this is an image which I told you already. So you can see a lot of consolidated areas here. At the same time, you can see one area is cavitating also. And here there are another few areas of consolidation you can see. So this is nothing but a peripheral distribution. I told you whenever the peripheral distribution and its multiple consolidations and few lesions with cavity formation, always think about a septic emboli. The moment you think about septic emboli, think about infected endocarditis as a probable diagnosis, especially right side infected endocarditis, which is going to produce a shower of emboli into the pulmonary circulation, causing peripheral distribution of this consolidation and cavitation. So this is a case of an infected endocarditis of the tricuspid valve producing septic emboli to the lungs, proven case of ours. Clear? So understood. So these are some of the images I want to show in lung abscess. Next, let us see the differential diagnosis for thick-walled as well as thin-walled cavities. So when you are going to call a thick-walled cavity and when you are going to call it as a thin-walled cavity. So definition wise, whenever the wall thickness is more than 5 millimeter, we call it as a thick walled cavity. Whenever the wall thickness is less than 5 millimeter, we're going to call it as a thin walled cavity. So the first DD for thick walled cavity is going to be lung abscess. The second DD is going to be vaginous. Third DD, squamous cell cancer. And fourth DD, probable one fungal infection called blastomycosis. Next, DD for thin wall cavities, obviously you have to think about tuberculosis as a first possibility, especially active TBs tend to produce thin walled cavities. Then it can be caused by traumatic lung cysts. These are not true cavities, but cystic lesions, traumatic lung cysts. It can be seen with other fungal infections like coccidioidomycosis, and finally with pulmonary metastasis. Mets generally tend to produce a thin walled cavity only. But remember, one cancer of whose metastasis in the lungs produce thick walled cavities is adenocarcinoma. Remember, de novo lung native squamous cell carcinoma produces thick walled cavities only. But squamous cell carcinoma metastasis to the lungs from elsewhere will produce thin walled cavities only, like other meds. But adenocarcinoma is very notorious because they can produce thick walled cavities. It's a paradox, irony, you have to understand. So adenocarcinoma metastasis tend to produce thick walled, and squamous cell carcinoma metastasis produce thin walled cavities, but a de novo lung native squamous cell carcinoma tends to produce a thick walled cavity only because of that propensity to produce lung abscess by bronchial obstruction. But not only tuberculosis, any other non-tuberculous mycobacteria, you can also remember, they are also going to produce thin walled cavities only. Fine. So when the wall thickness will be suggestive of a cavity. Remember, whenever the wall thickness exceeds 20 millimeter, that is 2 centimeter of wall thickness, this is in favor of malignancy, heavily. This in heavy favor for malignancy. You have to know that whenever the wall thickness is more than 20 millimeter, highly in favor of malignancy. Clear? Fine. Now we are going to differentiate between a lung abscess versus a empyema. Obviously, the major difference between lung abscess and empyema, both are going to be formed by pus only, but the most important difference is very simple because it's lung based. This lung abscess is going to be lung based, empyema is going to be pleural based. Very simple, right? It's going to be pleural based. This one difference, if you understand it's enough, you can tell any difference between the lung abscess and the empyema. For example, if you take the lung and if you want to draw a diagram, so this is going to be the lung abscess and this is going to be the empyema, obviously. You can see the contact with the chest wall because lung abscess is more lung based and parenchymal based. You can see the contact with the chest wall is very narrow. But whereas since it's pleural based, the contact with the chest wall will be very big. So that's the first difference. So what is the contact with the chest wall? Here it tends to be narrow, but whereas in empyema it tends to be broad contact with the chest wall. Obviously, since it's parenchyma based, this lung abscess, you're going to result in surrounding consolidation and maybe increased bronchovascular markings also. So presence of surrounding parenchymal issues. What are the surrounding parenchymal issues? Like consolidation, infiltrations, increased bronchovascular markings. All these things are very common in a lung abscess. You don't get this in a empyema. And obviously the shape of the lung abscess tends to be more round and spherical, whereas the shape of the empyema tends to be more lenticular in shape. That's why naturally itself my hand went in that manner, like lung abscess I drew round and empyema I drew more in a lenticular fashion because it's located between the two pleural surface. So it tends to be naturally a lenticular shape only. Clear? So then will there be any pleural thickening? Obviously no in case of lung abscess, yes in case of a empyema. And that's why I told you it's pleural based, it's lung based. So that's why you get pleural thickening, and this pleural thickening is also responsible for getting one of the very important signs, called as a split pleura sign. Very, very important sign. It's called a split pleura sign, where the parietal vessel pleura will be thickened. It will appear like pleura is split into two. So we'll see that sign in some time in a CT, split pleura sign. Then what about the air fluid levels? The air fluid levels are very common in a lung abscess compared to that of a empyema. It's very rare. Even if it is common in lung abscess, it tends to be equal. Even if it is rare in a empyema, it tends to be unequal in length, air fluid levels. Okay. And adjacent collapse. Again, adjacent collapse is a very common feature of a empyema compared to that of a lung abscess. Why? Because this mass extrinsic to the lung only can compress on the lung and produce adjacent collapse. Empyema is like a mass that is originating extrinsic to the lung parenchyma. So it can expand and it can collapse the adjacent alveoli. So adjacent collapse is a feature of a empyema, not a lung abscess. And finally, claw sign. Claw sign is a feature of lung abscess only. It's not a feature of empyema. So what do you mean by claw sign? So remember, this claw sign is not something you can tell only in the lung abscess and empyema difference. You can tell in any other area where you want to differentiate between a mass that is originating intrinsic to the particular structure, or if it's a mass that is originating outside a structure and it's distorting the outline of that particular structure. So to differentiate these two things, between intrinsic mass to the structure or extrinsic mass to the structure, we are going to use a sign called a claw sign. So let us see how it works. Suppose if a mass is originating within that particular solid structure, they will form sharp angles like this, and there can be a rim of parenchyma that is surrounding the mass, and majority of the mass will be surrounded by the parenchyma. That's the idea. And more importantly, as I told you, they form this kind of acute angles, which means angles less than 90 degree. And the angle between the mass and the parenchyma will be acute and sharp. So this is what we refer to as a claw sign. Suppose if the mass is originating outside the parenchyma, which is extrinsic to the solid structure, and if it just distorts the outline of the solid structure, so how it will be? It's going to be like this. So which means majority of the parenchyma will not be in contact with the mass, number one. At the same time, they don't form any sharp angles with the parenchyma. So which means claw sign will be negative. So this is an extrinsic mass, this is an intrinsic mass. So this is the basis of claw sign, and this claw sign is helpful to differentiate intra-axial mass versus extra-axial mass, which means within the parenchyma versus outside the parenchyma of a particular structure. For example, it can be useful to differentiate between a lung abscess, which is intrinsic to the lung parenchyma, versus an empyema, which is outside the parenchyma. Similarly, it is helpful to differentiate with intraaxial brain tumor, which means some tumor that originates within the parenchyma of the brain, versus a meningioma, which is an extraaxial tumor which originates outside the parenchyma of the brain. Number 3, it can also be used to differentiate between a Wilms tumor, or otherwise called a nephroblastoma, which originates within the parenchyma of the kidney, versus a neuroblastoma, which is going to originate outside the kidney parenchyma, which may compress on the kidney bud. Or it can also be used to differentiate between a tumor called an angiolipoma, which is a renal tumor. It's a benign tumor originating from the kidney, versus a retroperitoneal sarcoma, which is a tumor that may compress on the kidney, but it originates outside the kidney parenchyma. Clear? So which means all these are intraaxial tumors, which means they are present within the parenchyma and they are going to exhibit claw sign. But this empyema, neuroblastoma, meningioma, retroperitoneal sarcoma, all these things, they won't exhibit this characteristic claw sign. Clear? So these are, the claw sign, you can understand the basic principles of the claw sign, so which means you can understand clearly it is not something very specific to particular lung abscess or intraaxial brain tumor. It can be seen in any condition to differentiate between a intrinsic mass to the particular solid structure versus extrinsic mass to the solid structure. Clear? So now let us see some of the images to substantiate this. You can see there are 2 images which I have shown you here. In the same patient, you are having a lung abscess which is more spherical. Along with the same patient also has an empyema which is more lenticular in shape. So this is more spherical in shape, this is more lenticular in shape. I told you it's lung based, so you can see the contact with the chest wall is very less. Contact with the chest wall is very less. but you can see it has a huge contact. It has a very broad contact with the chest wall, empyema, because it's pleural based. And you can see the surrounding pleural thickening here. So you are seeing a surrounding pleural thickening, and it is thin walled because it's pleura. But you can see a very thick wall here. At the same time, it is surrounded by consolidation, not by pleural thickening, not by pleura. It's surrounded by consolidation. Clear? And this is the hallmark that we call it as a split pleura sign. You can see this is the visceral pleura and this is the parietal pleura. So both are thickened and surrounding that abscess. That is what we refer to as a split pleura sign. Very, very specific for empyema, split pleura sign. And you can also see the fact that they form acute angles with the parenchyma. Clear? So these are sharp and acute angles with the parenchyma, which means they are exhibiting the claw sign. So that is why this is a lung abscess. So these are some of the differences between lung abscess and empyema, very important for exams. Now let us move on to the management of lung abscess. The treatment of lung abscess, the primary treatment is going to be by antibiotics because it's an infection. Interventions are also done. I'll tell you the indications in some time. So you have to give antibiotics that are anaerobic cover. Clear? It's a very important thing. You have to give antibiotics that are anaerobic cover because lung abscess tends to be polymicrobial with very strong anaerobic contamination. That is the reason. So what are the antibiotics that you can use for anaerobic cover? Number one, clindamycin. Clindamycin is thought to be the traditional drug of choice for lung abscess. But even though this is a myth and why it should not be used as a first line choice, I'll tell you in some time. You can use it, but right now we prefer other antibiotics or clindamycin for treatment of lung abscess. But why this notion came is the fact that it was suggested previously that any anaerobic infection above the diaphragm, treatment of choice is clindamycin, and any anaerobic infection below the diaphragm, the treatment of choice is metronidazole. So this was the notion. So why it came? Because you have the lung and you have the oral cavity, and majority of the anaerobic contamination that happens in the lung and the oral cavity will be done by gram-positive anaerobes. But particularly notorious, one important anaerobe is there that is called Peptostreptococcus, which is a classic gram-positive anaerobic organism. So for the same reason, clindamycin covers a gram-positive anaerobe much better than a gram-negative anaerobe, and cover against Peptostreptococcus is very good. That is the reason why they considered this clindamycin as a drug of choice for infections above the diaphragm, which is predominantly by gram-positive anaerobes. Similarly, for gram-negative anaerobes, metronidazole is considered to be very good. Why? Especially below the diaphragm, because below the diaphragm, the anaerobic contamination will be usually due to a very important gram-negative anaerobic organism called Bacteroides fragilis. And since metronidazole covers this Bacteroides fragilis excellently, even now the gold standard for Bacteroides fragilis is metronidazole only. So that is the reason they considered this metronidazole as the drug of choice for anaerobic infections below the diaphragm. But this is the notion that came. But apart from that, a lot of other drugs, including certain natural penicillins, have good anaerobic cover, if not the best, and a lot of other aminopenicillins, your carbapenems, cephalosporins, certain cephalosporins, all these things tend to have a very, very good anaerobic cover. So what are the other drugs that you can use in lung abscess which has excellent anaerobic cover? For example, ampicillin sulbactam, excellent anaerobic cover. Piperazolin tazobactam, very good anaerobic cover, and a lot of carbapenems like imipenem, doripenem, meropenem, ertapenem, all these things also have a very good anaerobic cover. Clear? So you can use any one of them. And one important fluoroquinolone called moxifloxacin has a very good anaerobic cover. Clear? Usually the fluoroquinolone generations are highly ambiguous and different textbooks will give different answers, but my general view, I'll classify into 4 generations. This is my principle. This is a theoretical as well as very practical principle that will help you in your practice. So one is called nalidixic acid. Second one, you have norfloxacin, ofloxacin, and ciprofloxacin. All these things will come under second generation. Then you have third generation where you have levofloxacin and gemifloxacin, and fourth generation where you have moxifloxacin. All the generations of quinolones have excellent gram-negative cover. There is no doubt about that. But this moxifloxacin alone cannot be used in UTI. Remaining all the 3 generations can be used in urinary tract infection. Clear? Why? Because this moxifloxacin has a very poor urinary penetration. Poor urinary penetration. Other quinolones have excellent urinary penetration, but moxifloxacin has a very poor urinary penetration. At the same time, this third and fourth generation quinolones have good activity against gram-positive organisms as well as atypical organisms. So they are broad spectrum. They have gram-negative, atypical as well as gram-positive cover, third and fourth generation quinolones. That led to a common notion telling this third and fourth generation quinolones are often considered as a respiratory quinolone. Often considered as respiratory quinolones, where they are used to treat moderate to severe pneumonia. Anyway, pneumonia LRT is the main reason why we give this third and fourth generation quinolones. In particular, this levofloxacin is a very commonly used drug. And what are the antibiotics? What are the quinolones that have pseudomonal cover? The second and third generation quinolones have pseudomonal cover. In particular, this ciprofloxacin and levofloxacin have a very good pseudomonal cover. Among the two, if you choose, I'll choose Cipro, which has a very, very good pseudomonal cover. And finally, this moxifloxacin also has a atypical cover. If they ask you, moxifloxacin also has an anaerobic cover. If they ask you among all the fluoroquinolones, which has a very good and excellent anaerobic cover, it is moxifloxacin only. So that is the reason why we are using moxifloxacin as an agent in treating lung abscess when we suspect anaerobic contamination. So because among all the fluoroquinolones, only this moxifloxacin has a good anaerobic cover. So this is a very practical classification I have given, but even though don't get confused by seeing a different classification in a different pharmacology textbook, this is a very clinical and a practical one, because this Levo, Moxi and Cipro are the most commonly used fluoroquinolones in India at present. So these are the antibiotic choices that we are going to do. So what are the indicators? I'm not talking about indication. Indicators of failure to therapy, which means your antibiotics will not work, probably will not work. So what are the indicators? Number one, very large abscess. If the abscess size is more than 6 centimeter in diameter, very large abscess, you're not going to get resolved with antibiotics. Obviously, if you have endobronchial obstruction causing abscess, obviously only when the obstruction is cleared, you will get resolution of the abscess, otherwise you won't. Number 3, if your abscess is made of resistant organisms like Pseudomonas. So these are the 3 indicators of a failure to medical therapy, failure to antibiotics. Suppose if really your medical treatment fails, you can go for certain interventional management. For example, you can do a lobectomy or a pneumonectomy, depending on the case-by-case indication. Or you can do other less problematic procedures like a percutaneous drainage or a endoscopic drainage via bronchoscopy or a pigtail catheter. So you can do all this also. So these are also done. So only if the medical management fails, then only you are going to do all these things. So these are some of the treatment of lung abscess. These are the treatment aspects of lung abscess. With this, we have completed the lung abscess also. We can move on to the next topic, that is ventilator-associated pneumonia, VAP. Clear? Before going into VAP, you have to know the definitions of HAP as well as VAP, which I have mentioned already, but let me tell you again. HAP is an hospital-acquired pneumonia which happens after 48 hours of admission to the hospital. If it happens before 48 hours of hospital admission, it will be taken as community-acquired pneumonia only. Only after 48 hours of admission to the hospital, if a pneumonia happens, that's called a hospital-acquired pneumonia. Ventilator-associated pneumonia, when it happens after 48 hours of endotracheal intubation and connecting to the ventilator. Clear? So only it happens after 48 hours of intubation, we call it as ventilator-associated pneumonia. Okay? So if it happens before 48 hours, it could be either a hospital-acquired pneumonia or a community-acquired pneumonia, depending on how long the patient is being staying in the hospital. So after 48 hours of endotracheal intubation, this is what we call it as a classic ventilator-associated pneumonia. So what are the types of VAP? We have 2 types of VAP. by timing, that's called the early VAP and the late VAP. Early VAP happens within 4 days of endotracheal intubation. Late VAP happens after 4 days of endotracheal intubation. Early VAP characteristic feature is usually organisms will be sensitive organisms. It will be made of sensitive organisms like what you see in CAP, very sensitive. But whereas more than 4 days, late VAP is associated with incidence of resistant organisms like MRSA, Pseudomonas, Klebsiella, Acinetobacter. A lot of resistant organisms will be there if it's especially a late VAP. So this is the importance of the timing of the ventilator-associated pneumonia. But what is the most common cause of ventilator-associated pneumonia? Asking about the most common organism itself is not a very good question because most of the organisms in VAP will be resistant, and that's what is important, not the exact organism that is going to cause VAP. At the same time, the difference in proportions between different organisms in ventilator-associated pneumonia will be very, very marginal. For example, if you tell the most common organism, that will defeat the second most common organism by just 1 or 2%. That really doesn't make any sense according to me. But still, since a lot of students were asking what is the most common, so let us see the CDC data that was compiled in 2009 and 10, which included 8,474 ventilator-associated pneumonia cases, and this is the largest sample size I have seen in a single study that has made for ventilator-associated pneumonia. That's why I'm taking this as a evidence, and again it's coming from a large body of evidence called CDC, US, Center for Disease Control. So where they told the most common organism in the ventilator-associated pneumonia was Staph aureus. Staph aureus was supposed to be the most common, followed by gram-negative bacilli or gram-negative rods. This is supposed to be the second most common. Among the gram-negative bacilli, they told Pseudomonas were the most common among the gram-negative bacilli, followed by other organisms like E. coli, Acinetobacter, Klebsiella, Enterobacter, and related organisms. Cool. So now, among all the gram-negative bacilli, Acinetobacter showed the highest resistance rates, very, very high rate of MDR organisms. Almost 60 to 70% of Acinetobacter isolates were MDR, multi-drug resistant. But the lowest rates for MDR is seen with E. coli. Less than 10% of the E. coli isolates were MDR. So lowest rates. Among the gram-negative bacilli, highest is Acinetobacter to have high rates of MDR, but the most common is Pseudomonas. Staphylococcus aureus, you might ask me which is more common, MSSA or MRSA. They couldn't make out because MSSA and MRSA are almost equal incidence, 50-50. That's why they couldn't make out. So Staph aureus is the commonest, followed by gram-negative bacilli. Among the gram-negative bacilli, Pseudomonas is supposed to be the most common. Fine, all right. So with this, we can tell what are the risk factors for getting a ventilator-associated pneumonia. Remember, ventilator-associated pneumonia pathophysiology is quite simple. When the patient is intubated like this and you have a trachea and you know the patient will be having a cough, tracheal cough. This cough is the one that prevents the aspiration, right? So in an intubated patient, whatever secretions that are coming from the stomach, let us assume this is the esophagus and the GIT, gastrointestinal tract, and whatever secretion that are regurgitated that comes from the stomach will not enter the respiratory tract. Instead, it will pool in the area above the cough. This is where the secretions are going to pool, and that is why tracheal suctioning is very, very important. Not only tracheal, even the glottic suctioning and oral suctioning, all these things carry a lot of importance in critical care because you have to remove the secretions out. Otherwise, at some point, if the cuff pressure is not adequate, the secretions may travel down slowly and they may reach the lower respiratory tract. And this is supposed to be the reason for ventilator-associated pneumonia. At the same time, why these organisms has to travel all the way? That is because of translocation of bacteria. Translocation of enteric bacteria, they may even result in sepsis also. That is because of poor enteral nutrition and a lot of other reasons that are happening in a critical care ICU patient. So especially bacterial translocation will happen and there will be a lot of problems in critical care because enteral nutrition is the one that suppresses the bacterial translocation, and majority of the critical care patients will not receive adequate enteral nutrition. At the same time, these patients will be receiving a lot of PPIs also. PPIs is one of the risk factors for developing ventilator-associated pneumonia because PPIs will suppress the gastric acid because gastric acid is a very important protective factor against translocation of this bacteria towards the respiratory tract. But here you give PPAs and H2 blockers and you suppress the acid, and it's easy for all this bacteria to go through the stomach and go along the esophagus and reach the upper respiratory tract. So from there, if the cough leaks, and they go into the lower respiratory tract. So with this keeping in mind, this key principles of ventilator's pneumonia, let us see the risk factors of ventilator's pneumonia. What are the general risk factors? What are the risk factors for getting an MDR organism? And what are the preventive measures? Let us see all in one go. First, risk factor wise, first one is the elderly patients, especially who are aged more than 70 years, definitely risk factor. Apart from that, anyone with chronic lung disease, obviously lung disease, pre-existing lung disease is a risk factor. Low GCS, definite risk factor, again more risk of aspiration, that's why. And aspiration itself carries a ventilator's pneumonia risk, VAP risk is very high. Apart from that, your routine acid suppressing therapy like using proton pump inhibitors or H2 blockers routinely, again is a very important risk factors for ventilator-associated pneumonia. And use of broad spectrum antibiotics. Broad spectrum antibiotics again is important for bacterial translocation and very important for development of ventilator-associated pneumonia. Polytrauma case, risk of aspiration is very high. Reintubation, very, very important. Reintubation or prolonged intubation. Reintubation means you are going to remove the cuff and put a tube again. Whatever secretion that have been collected here, when you remove the cuff, everything will go down and easily will induce a VAP. And even in a prolonged intubation, that's a risk, because in prolonged intubation, the cuff pressure may not be adequate, or maybe surrounding mucosal necrosis might happen. Because of that, the secretions might track down and produce a LRTA, that is ventilator-associated pneumonia. So avoid reintubations as much as possible, and frequent changing of ventilator circuits. Frequently changing ventilator circuits again is going to have a very high incidence of VAP. It's actually paradoxical to what a normal student thinks, that intubating again and again or frequently changing the ventilator tubes may have a good impact. Actually, it's not. It's going to have a pretty bad impact. So don't do that. So now we can see what are the risk factors for getting an MDR organism. Risk factor for getting an MDR organism, most important ever, is prior use of antibiotics, especially in the last 90 days, that is 3 months. Especially if you're using an IV antibiotic, it carries even more higher risk. Point number 1, absolutely important. Number 2, if the patient is having ARDS, preceding VAP, which means preceding ventilator pneumonia, the patient is having a ARDS. Number 3, the patient is having septic shock at the time of diagnosing VAP, very high risk of MDR organism. Number 4, late ventilator pneumonia, late VAP. We discussed already, this is going to have a high risk of MDR organism. Then acute renal replacement therapy, and the patient is getting VAP subsequently, which means the patient is on dialysis in simple terms, and the patient is getting a subsequent ventilator-associated pneumonia. Very, very high risk of MDR organism. In fact, any dialysis itself is a high risk of MDR organisms in the hospital. What are the preventive measures that you can employ? Traditional and the most emphasized one obviously is going to be the hand washing. Point number 1. Number 2, head end elevation, where the patient can be put in a semi-recumbent position. Typically around 30 to 60 degree head end elevation is very beneficial, because this might result in less aspiration of the gastric secretions and lesser incidence of VAP. Third, avoiding nasal endotracheal intubations. Some surgeries selectively they do nasal endotracheal intubation like tonsillectomy and all, but in general for critical care patients we avoid nasal endotracheal intubation. Again, don't do that. And fourth is routine suctioning of subglottic secretions. The subglottic secretions are predominantly from the GIT. So they are the ones that are going to contain this resistant gram-negative rods. So whenever you have subglottic secretions, you keep aspirating it again and again, so that you don't make that area full of secretion, so that they can drain down and they can produce a lower respiratory tract infection and a VAP. So routine suctioning of subglottic secretions has a big value. And avoid unnecessary proton pump inhibitors or H2 blockers. So avoid unnecessary acid suppression therapy. do acid suppression only in necessary cases. What are the indications for acid suppression? We'll discuss in GID section. But right now, I will just tell, don't give acid suppression to all the cases unnecessarily in critical care as a routine basis. But there was a study which compared this sucralfate with standard acid suppression therapy. Use of sucralfate instead of H2 blockers and PPIs had a lower incidence of VAP, but a higher incidence of bleeding, gastrointestinal bleeding. So this is a very important study, again, sucralfate study, but anyway, they reduced the incidence of VAP. That's what you have to know. But avoid unnecessary acid suppression as much as possible. Number 6, silver coated endotracheal tubes. The studies that demonstrated about the silver coated endotracheal tubes, all of them have proved that there is a reduced incidence of VAP. But the problem is there is no change in the mortality. Even if you use a silver coated tube or not, the overall final endpoint mortality is not going to change. But even though they had a reduced incidence of ventilator-associated pneumonia. Finally, early enteral nutrition. I told you absence of enteral nutrition is again a very important risk factor for bacterial translocation. For avoid that, give early enteral nutrition. So that's also very important point. And avoid unnecessary total parenteral nutrition, TPNs. So do not use parenteral nutrition as much as possible. Go for enteral feeding. Okay, so these are the risk factors, preventive measures, and MDR risk factors. All these things we have seen. Now we are going on to the clinical features. So what are the clinical features of VAP and how you are going to diagnose VAP? More than clinical features, how we are going to suspect a VAP. Point number 1, if the patient is getting a new fever when the patient is on a ventilator, patient is having a new increase in the WBC counts when the patient is on a ventilator, or patient is getting a new chest X-ray infiltrate when the patient is on a ventilator. Number 4, if the patient is having a worsening hypoxemia in a ventilator, this can have a lot of causes. And if the purulence of ET secretions are increasing, or I can write increased purulence of ET secretions, which means the ET secretions are becoming more and more pus-based, more and more purulent. You can suspect there is something going on. Whether you can predict based on some scoring system, answer is yes. We have a very important scoring system called CPS, that is called a clinical pulmonary infection score. This is for ventilator-associated pneumonia only. Like how you have curve 65 for community-acquired pneumonia and how you have PSI, pneumonia severity index for community-acquired pneumonia. Similarly, your smart COP tool predicts ICU admission in a community-acquired pneumonia. Similarly, this score is exclusively for predicting ventilator-associated pneumonia, CPAS score, clinical pulmonary infection score. There are 7 parameters that are used. One is the temperature. Second is the nature of secretions, nature of tracheal secretions the patient is having, the total WBC count, PaO to FaO2 ratio, that's going to depict the oxygenation, chest X-ray to look for the infiltrates. Then we can see the progression of infiltrates also. And finally, the culture of the sputum or the ET aspirate. So in this, the first 5 are done on day 1. The remaining 2 are done on day 2, 3. Clear? Assessed, at least assessed on day 2, 3, remaining 2. Because you cannot assess the culture or you cannot assess the progression of infiltrate on day 1. So that's why it's a very sensible thing. The remaining 2 are assessed on day 2 and 3. The first one is assessed on day 1. Each and everything has a score of 0 to 2. Each and every point has a score of 0 to 2, which means the total score will range from 0 to 14. Any score more than 6 indicates high probability of VAP, ventilator-associated pneumonia, high probability for diagnosing a ventilator-associated pneumonia. So let us see the score. What is the score? So this is the score I mentioned here, where you can see each and everything. Already I mentioned, so temperature, WBC count, nature of tracheal secretions, PaO to FaO2 ratio, there is oxygenation, chest X-ray, progression of the chest X-ray infiltrates, and culture. Finally, everything is going to have a score of 2. So 7 into 2, totally will be getting 14. Anything more than 6 is significant. So this is the CPAS, that is clinical pulmonary infection score. Now we'll move on to the diagnostics, which means how will you do a microbiological diagnosis. So there are 2 ways of doing a microbiological diagnosis. One is a non-invasive method and second one, invasive method. So non-invasive method means it's very simple. We are going to do an ET aspirate. One of the biggest advantage of doing an ET aspirate is extremely cheap and easy to do, which means even a staff nurse can do this. So easy to do, right? So just take the occasional ET tube and send it for culture. Invasive techniques, on the other hand, it's cumbersome, but it's still specific but very cumbersome to do, which means it needs an expert. Definitely, it needs an expert who has to do this procedure. For example, a bronchial lavage ball, it needs a pulmonologist or any expert who's specialized in doing a bronchoscopy, or a mini bronchial lavage, or you can do a protected specimen brush. That's called PSB, protected specimen brush. So what do you mean by PSB? PSB is a brush that is protected by a plastic sheath, and you enter through the bronchoscope in the area of chest extended. You know the area of chest extended filtrate. You go to that area and remove the sheath, and now the brush will be exposed, and take the specimen sampling from that area, brushings, and close the area, the brush with the sheath again and come out. Which is, by this technique, you are exposing the brush only to the area of suspicion. So it is a very, very highly specific investigation. If they ask you the most specific among all, it's going to be protected specimen brush only. And that also becomes a very big advantage as well as disadvantage, which means the sensitivity of ET aspirate is very, very high, but they suffer from poor specificity. Whereas the sensitivity of invasive techniques are a bit low, but they have a very, very good specificity, excellent specificity. Why the specificity is low? And this is because sometimes you might encounter organ, because since you are doing an ET aspirate, sometimes the organism that you're isolating may be simply an upper respiratory organism, or even from a oral secretion also. So it may not be that specific. That's why specificity is low. And one important point is this ET aspirate can miss your lower infections, lower respiratory infections sometimes. If it's deep down, the ET aspirate can easily miss, because the secretions may not reach that level, because patient is not actively coughing in a ventilator. So they can miss a low respiratory tract infection that is very deep down. So this is one problem with the ET aspirate. But let us see what type of culture techniques that they are doing with these two. There are two types of culture techniques. One is called semi-quantitative culture techniques, and next is quantitative culture techniques. So whatever the specimen you take, either from a ball or a mini ball or a PSB or from ET aspirate, you send for cultures. So if the culture report says mild growth, no growth, moderate growth, or heavy growth, this is what we refer to as semi-quantitative cultures. Among the semi-quantitative cultures, this moderate and heavy growth only are taken as positive, whereas this mild and no growth will be insignificant only. Quantitative cultures will generally report in colony forming units per ml. So the diagnostic threshold or diagnostic cutoff for different investigations are little bit varying. So first, in an ET aspirate, the diagnostic cutoff for diagnosing a ventilator-associated pneumonia is approximately more than or equal to 10 power 5 colony forming units per ml. Whereas in a ball or a mini ball, the threshold is at 10 power 4, 10,000 colony forming units per ml. Whereas for a PSB, it's the most specific. So even seeing 1,000, 10 power 3 colony forming units per ml is considered to be diagnostic. It's a diagnostic threshold. So, but what your ATS and IDSA guidelines are recommending? ATS and IDSA guidelines are recommending non-invasive techniques with semi-quantitative cultures. That is more than enough to diagnose a ventilator pneumonia based on the trial studies, which is more advantageous, which is going to pick up more case at the same time, which is going to make an impact in the mortality. So that's what the ATS IDSA guidelines will pick up. So what they have picked up is, they told a non-invasive technique like ET aspirate with semi-quantitative cultures are more than enough to diagnose a ventilator-associated pneumonia. Okay, so this is what ATS IDSA guidelines are currently recommending. American Thoracic Society and Infectious Disease Society of America. How will you treat the VAP patients? Remember, whatever I'm going to tell the treatment for ventilator-associated pneumonia, the same treatment you can use for hospital-acquired pneumonia also. So there is no much difference. So first, whenever you start treating a HAP or a VAP, in this case, it's a ventilator-associated pneumonia. First, see whether there is risk factor for MDR or not. I'm writing no risk factors for MDR organism. We already seen what are the risk factors for MDR organism, like renal replacement therapy recently, or patient used IV antibiotic in the last 90 days, or ARDS at preceding diagnosis of ventilator-associated pneumonia, or septic shock at the time of presentation. All these things like going to tell you that the patient is having a high risk of having a associated multi-drug resistant organism. So if there is no risk factor for MDR, your strategy of antibiotics should be in such a way that they should cover a gram-negative organism, a Pseudomonas organism. Pseudomonas is very important for HAP as well as VAP because Pseudomonas is a typical hospital organism. In hospital settings, you have to suspect Pseudomonas for sure. So it may be a VAP or a HAP. So it has to cover Pseudomonas, it has to cover gram-negative organisms also, and it has to cover MSS, that is methicillin-sensitive Staphylococcus aureus. And usually we prefer monotherapy as an empirical cover, which means empirical monotherapy is what we prefer, which means a single antibiotic should cover all these three: gram-negative, MSSA, and Pseudomonas. So what are these? So any one of these drugs you can use: piperacillin tazobactam, or a cefepime, or a levofloxacin. So this is what you're going to prefer. So any one of them you can use, which are excellent. In our hospital, we prefer piperacillin tazobactam, or even carbapenems can be preferred, but that's too much. So we can prefer piperacillin tazobactam itself, which is more than enough. So if there is a risk factor for MDR organism, you have to give multiple cover. Usually we prefer a double therapy. So the first drug should have, whatever drugs you use, they should have anti-pseudomonal cover, very important. At the same time, they should cover gram-negative organisms, and they should cover MSSA also. So these are the drugs you should use. The first drug, you can use a piperacillin tazobactam, or a cefepime, or a carbapenem like imipenem or meropenem, or a monobactam like aztreonam. In case if you have a penicillin allergy, we have seen in detail in the previous video itself. And you can use ceftazidime also, but currently it's getting outdated. And yeah, so these are the drugs that you're going to prefer. In our hospital, again, we prefer either a piperacillin tazobactam or a meropenem. And the second drug that you're going to add should have anti-pseudomonal activity also, but it acts as an adjunctive drug. So for example, we use a quinolone, anti-pseudomonal quinolone, or a aminoglycoside agent. This is what we're going to prefer. You know the anti-pseudomonal quinolone, there are only two that we commonly use, that is levofloxacin and moxifloxacin. In general, we prefer a levofloxacin. Aminoglycoside that you can use is, it could be amikacin, or it could be tobramycin, or it could be gentamicin. These are the common aminoglycosides we use that has anti-pseudomonal cover. So these drugs will have anti-pseudomonal cover, and at the same time, majority of the combination what we are adding, beta-lactams what we are adding, is going to check for MSSA also. MSSA will be covered under them. At the same time, they cover majority of the gram-negative organisms, which means a broad spectrum cover. Fine. So what are the examples of combination? I can add a piperacillin tazobactam with the levofloxacin, or I can add a piperacillin tazobactam with the amikacin also, or I can prefer adding a meropenem with the levofloxacin, or I can prefer adding a meropenem with the amikacin. So you can try these kind of combinations. Very common combination in our hospital is either a piperacillin tazobactam with levofloxacin or a meropenem with amikacin. This is what I prefer usually, but there is no like standard choice for all these things. It's all my personal belief, but you can try any of these combinations. One drug you can try from the first, and one drug you can try from the second, and make it a combo. That's all. Suppose under all these settings, if your hospital has a high risk of MRSA, increased risk of MRSA, then what you will do? Then you have to add vancomycin to your regime, because it's not a community acquired MRSA, it's a hospital acquired MRSA. We are talking about hospital acquired because HAP and VAP are hospital acquired only. The definitions are variable. So you have to suspect MRSA, and you have to add MRSA cover also. So when you will add MRSA cover, not in all the patients, it depends on your local policies, and again it depends on your microbiology department reports, which say in the last 1 to 3 months, if your hospital isolates whatever Staphylococcus aureus isolates they're getting in the lab, if more than 20% are MRSA, that's the guidelines that are given in the Western standards. If your hospital isolates of Staph aureus are showing that more than 20% of the Staph aureus isolates are MRSA and not MSSA, then definitely you have to add vancomycin. Clear? So it's again empirical choice only. It's not based on the current MRSA, whether it's present or not. It's based on the previous records in the hospital that shows more than 20% of the Staph aureus isolates were MRSA in the last 1 to 3 months. Then you are definitely adding vancomycin to the regime. So the empirical regime of choice will be, if you are having a risk factor for MDR organism, you can add piperacillin tazobactam, example, you can add a levofloxacin. Plus, if you have MRSA suspicion, that's so that your hospital is having more than 20% rates of MRSA in the last 1 to 3 months, you can add additional vancomycin also. Clear? So these are the regimens that you're going to use for a ventilator-associated pneumonia. Remember, the same treatment you can use for hospital-acquired pneumonia also, which means the same regimen you can use for both HAP as well as a ventilator-associated pneumonia. Clear? So with this, we are completing the second section of the pneumonia also, which means it has an extensive coverage on lung abscess, aspiration pneumonia, as well as a ventilator pneumonia and a hospital-acquired pneumonia. In the next section, we'll be discussing more of a childhood respiratory infections and other important respiratory infections like influenza, which are still ignored by many of the students. So with this, we'll close on the topic and move on to the next one.